Hey y'all, welcome back. I'm Mama Dr. Jones, a board-certified OBGYN and mom to four, and today we're talking all about VBAC, which is vaginal birth after cesarean delivery. If you're new here and you'd like to subscribe, I would love to have you. We talk about all things periods, pregnancy, sex ed, and everything in between. Hit that subscribe button, turn on notifications so you never miss an upload. Let's jump into the video. Let's start off with some basic definitions. VBAC is vaginal birth after cesarean. This refers to somebody who has a vaginal delivery when in a previous pregnancy they've had a cesarean delivery. We also sometimes use the word TOLAC, T-O-L-A-C. This is trial of labor after cesarean, meaning you are hoping to have a vaginal delivery, but we don't yet know what the outcome of that delivery will be. You might end up with a repeat C-section, or you might end up delivering vaginally like you had hoped. As always, everything I include in this video is purely for educational purposes and is not meant to be individual medical advice for you. If you are watching this video, it is simply to give you information so that you can bring up questions with your doctor or advanced practice provider and get the best information specific to your body and your pregnancy. So what are the benefits of having a vaginal birth after a cesarean? If you've had a C-section in a past pregnancy, why would you maybe choose to avoid that in this one? Most obvious in this is avoiding a major abdominal surgery. There is typically a shorter recovery time for a normal vaginal delivery than a C-section, although there can be complications that arrive during or just after a birth that could cause the vaginal delivery to have a longer recovery period. For the most part, you're going to have a longer recovery period if you have a cesarean delivery. The future pregnancies are going to be more likely to be vaginal deliveries as well. So when I talk to my patients about this, I always go over the idea of how many pregnancies or what size family they want to have. This is important because there's a very big difference to someone who says, oh, this is my second pregnancy and my second delivery and we are done. I want my tubes tied. And someone who says, we want a really big family, 6 or 7 or however many that we can have, we would love to have. In that first scenario, I'm going to counsel the patient a little bit different. We're going to talk about, okay, you want your tubes tied. We could do that at the time of the C-section. It's still reasonable to have a vaginal delivery. Let's go over the risks and benefits. In this other patient, if they're having their second delivery and the first one was a C-section, but they tell me, I want a really big family, I'm going to talk to them about the fact that compounding C-sections, so once you have 2, 3, 4, 5, more and more C-sections, is more and more risk. So each one gets slightly more risky. There's not a cutoff to the amount of C-sections you can have, but certainly we start getting more and more worried about complications and risk with each additional C-section. So people who definitely want big families might be more motivated to go for a vaginal delivery than somebody who is having their second baby and that's it, they're done. So this is a different conversation and should be individually personalized to the patient that you're speaking with. So what are the risks to TOLAC or VBAC? There is a generally increased risk to both the person having the baby and the neonate with a TOLAC as compared to a scheduled cesarean delivery. We have to discuss this in a way that makes sense. What's the safest way to have a baby? A normal vaginal delivery. What's the second safest way? A scheduled repeat C-section. What's the third safest way? A C-section that happens in the process of labor. Obviously, going into this, you don't know if you'll fall into number 1 or number 3. These are not really easy to compare one-to-one. As compared to a scheduled repeat cesarean delivery, TOLAC is going to have an increased risk of infection, increased risk of blood transfusion, and an increased risk of something called uterine rupture, which we'll talk about in a moment. As far as risks to the baby, you do see a slightly increased risk of seizures, needing respiratory support, and even neonatal mortality or death with VBAC. However, really important in my opinion to discuss absolute versus relative risk. There is a slight increase in the relative risk, but the absolute risk of all of those things remains incredibly low. For most people, that slight increase in risk is outweighed significantly by the benefits of avoiding a major abdominal surgery. This is person dependent and definitely an individual decision to be made. Now let's talk about the risk that everybody talks about first in this discussion most of the time, which is uterine rupture. So what is this? Uterine rupture is when a scar on the uterus where a previous incision had been brought back together comes apart during the process of labor. This is a rare but potentially life-threatening complication that can happen in somebody who's had a prior C-section and is planning for a vaginal delivery. The risk of that is incredibly low. If you've had one prior cesarean delivery, the risk is about 0.5%, which is 1 in 200, and all of those will not be catastrophic. Some of them will, and some of them will just be minor. And the risk in a scheduled C-section, because it can happen prior to the time that the C-section gets done, so there's still a risk, in any pregnancy when you have a prior uterine scar is about 1 in 3,000. So that's a significant difference in risk, about 18 times higher in people who are planning a trial of labor after a cesarean. However, the absolute risk is still incredibly low. And of those people who have the uterine rupture, the risk of that being catastrophic, meaning someone dies, the fetus dies, somebody needs blood transfusions, hysterectomy, things like that, which are all possibilities, is still relatively low. So a risk, a real risk, one to be considered and taken seriously, but still relatively uncommon, even in people who choose to have a TOLAC. In the process of labor, for somebody who chooses a trial of labor after cesarean or TOLAC, we're going to be watching the baby's heart rate closely. So we're going to want you to have continuous fetal monitoring. The reason for this is if a uterine rupture occurs, generally that's going to be identified or manifested, at least in some part, with a drop in the fetal heart rate. There are other things we watch for, but I think the most important thing here is that we highly recommend people have some kind of IV access so that if there is an emergency, we can take care of it, and continuous fetal monitoring so that if that uterine rupture does occur, we can notice that it's happening or potentially guess that it's happening as soon as possible and take care of it before it becomes a catastrophic problem. That's obviously not always possible, but it's certainly the goal. For people who choose a TOLAC, there's about a 60 to 80% chance that they will have a successful VBAC or vaginal birth after cesarean. These are pretty good odds. What are some things that you might be able to do to increase your success rate? Well, honestly, there's not a lot that you can do. You don't have a lot of control over this. Being as healthy as possible during the pregnancy, gaining the recommended amount of weight during the pregnancy, staying active and fit during the pregnancy, all the things that we know are associated with having an easier vaginal delivery in general are going to be things that are positive in the process of hopefully increasing the chances of a successful VBAC. The biggest predictor is your prior history. Why was the previous C-section done? Was it a indication that is something that doesn't repeat? The last baby was twins and they were both breech. The last delivery was a placenta previa and you don't have that this time. Or was it something like you got to 10 centimeters, you were pushing and pushing and pushing for 3 or 4 hours and the baby wouldn't come out. It was not poorly positioned. Everything else seemed fine. Obviously, the outcomes and what I tell a patient as far as do you think that this will be successful is going to be a little different between these two patients because this indication can recur and this one we could identify prior to the time of planning the delivery. So a common thing that I get asked is, why would my doctor say no? I have a doctor who I wanted to VBAC and they told me no. ACOG says that everybody who has one prior cesarean delivery and no other specific contraindications to vaginal birth should be offered a VBAC. That being said, there are safe places to have a VBAC and there are not as safe places to have a VBAC. If you are in a situation where you're delivering in a hospital that is unsupportive of patients having VBAC, or your doctor is in a group where other doctors are not happy to offer VBAC, I personally have experience with this where I'm definitely pro VBAC for the patient that wants it, but I knew if my patient wanted a VBAC and came in labor that I had partners who would not allow them to labor, which I highly disagree with. So I would recommend to those patients not delivering with me if they wanted a VBAC because I couldn't guarantee that I would be the one that was there and I can't control how other people practice. There might be a situation where you don't have in-house anesthetics. So when we had a patient who was a VBAC patient, we would stay in-house, meaning in the hospital the whole time they were in labor, because if something went wrong, we needed to be there to take care of them urgently. If you don't have an anesthesia team willing to stay in the hospital with you, and that's going to delay a surgery or an intervention by 30 minutes, which is time you don't have in a uterine rupture scenario, you may not be in a place that's safe to have a vaginal delivery. You also should be in a place that has access to blood transfusions and higher care like an ICU if required. Even though those things are incredibly low chances of happening, it's still something you want to be prepared for because it's a known risk that can happen. So there's a lot of reasons that your doctor might say no. Most importantly, the way that your previous C-section was done. So a contraindication, meaning you should not have a TOLAC, is if your previous uterine incision was done in an up and down manner or across the top of the uterus. Most C-sections are done through something called a low transverse incision. And that's important because it goes through the non-contractile portion of the uterus. When you make an up and down incision, it is in the contraction part of the uterus, the muscle part that contracts. And so that increases the risk of uterine rupture in the process of labor to a point that's thought to be unreasonably high risk. And we would recommend against TOLAC. How do you know if you had that? Well, you may not. It generally doesn't correlate to the way that your incision on the skin is done. If your incision is down low on the skin like a bikini incision, that doesn't necessarily mean the uterine incision was. And the skin incision has nothing to do with what we recommend. Most C-sections are done with a low transverse incision, but people who have really preterm babies or babies that were malpositioned or some kind of really scary emergency may have a different type of C-section. So this is really important to talk with your doctor about, or if possible, to get your previous op notes. If you have an unknown incision and it's reasonable to think it was probably low transverse, meaning you had a full-term delivery somewhere you just can't get your op note and it wasn't an emergency, it's probably fine to consider TOLAC, but that would be something to discuss with your doctor. Another common question is, what if I need to be induced? Induction is not contraindicated in somebody planning TOLAC. There are certain types of medications we avoid in inductions with TOLAC, and we want to be really careful to keep close track of the contraction pattern, but it is still possible to be induced if you want to have a TOLAC. This is going to be an individual discussion. It does slightly decrease the chances of a successful TOLAC, so you need to discuss this with your doctor and make a plan that's specific to you and the situation that you have going on, the reason for induction, and things like that. What if I've already had 2 or more C-sections? The American College of ObGyn says that although the risk of uterine rupture probably increases slightly in somebody who's had 2 prior C-sections, if they're an otherwise good candidate for TOLAC, then it's probably reasonable if the patient wants to consider having a VBAC. That being said, if the last 2 sections were done at 10 centimeters after pushing for 3 hours, the risk of having another C-section done in the middle of the second stage, which is the process of pushing, is probably not worth it. So this is very individual. After 2 C-sections, you're going to probably have more difficulty finding somebody who would be willing to let you have a VBAC. I personally think that a well-counseled patient with 2 or 3 prior sections who really wants to VBAC and understands the risks and benefits should be allowed to do that, because I strongly believe in autonomy. But again, you may not run into that with everybody, and you may run into someone who believes that like I do, but is under the rule of their hospital policy on what they can and can't offer to their patients. So there's some complexities that come in here that are not just personal physician beliefs or the evidence in what it says. What if you are having twins? Twins are not an absolute contraindication to having a TOLAC. If you have twins that are otherwise good candidates for vaginal delivery and you've had a prior C-section and your doctor is willing to discuss this with you and go through the risks and benefits, it's still reasonable, and you don't likely have an increased risk of uterine rupture compared to people who've just had a prior cesarean and are having a singleton VBAC this time. So the TLDR of that is, assuming there's no other contraindication to a vaginal delivery, a TOLAC would be a reasonable option in somebody with twins. What if your baby is breech? You can still have a external cephalic version, which is where we turn the baby from the outside from breech to head down, even if you've had a prior cesarean delivery. Some doctors are a little less willing to do this, but the data says that it's safe and a reasonable option in a well-counseled patient who desires that. So talk to your doctor, find out the best option for you. I think you will see through the course of this video that the crux of this is an individual decision. Nobody should make you feel like you are forced to have a C-section, and nobody should make you feel that you are forced to consider a TOLAC or VBAC. Your doctor should be able to offer you somewhere that you can go. Ethically, I think this is the only acceptable option in medicine if they are not at a place that is offering VBAC. That may not be somewhere close because they don't have control over that. But if they do not offer VBAC, or the hospital that you are planning to deliver at does not allow VBAC, they should be willing to refer you somewhere that does, if that's something that's really important to you. So know all of these things, watch this video, get this information, take it to your doctor so that you have questions, so that you can get the information that you need, and so that you can make an informed decision for yourself. Thank you for being here today. I hope that you learned something. If you did, leave a like on this video, comment down below something that you would like me to talk about in the future. I will link some other videos right over here, and I will see you next Monday.